Yeah, it's fine. I'm Kate Tila. I'm with the Bill and Melinda Gates Foundation. I'm on the maternal newborn child health team there. And I work a lot on our portfolio work specifically around maternal health care, as well as our country-based work in Nigeria. I'm a doula myself, so I'm also very interested in the women's kind of perspective and keeping the woman at the center of healthcare. So I'm very interested to hear what all of our panelists today have to say. So I'll go ahead and introduce the first panelist, but first I just want to say that there's 3 panelists instead of 4, so we have a little bit more time, so maybe each panelist can go for about 15 minutes. And then after each panel, we'll have a short question and answer time for questions that are specific to that presentation. And then at the end, after the 3rd presentation, we'll kind of open it up to more general questions and discussions that people want to have. All right? So first, I'd like to ask Mr. Chinedu Araka to speak. Mr. Araka is a medical student at the Nnamdi Azikiwe University Teaching Hospital in Anambra, Nigeria, where he's the chair of the Action Group on Adolescent Health, as well as the leader on a communications project group called the Build African Research Capacity Group. His interests are in biomedical research with a focus on sexual and reproductive health and rights, drugs, and diagnostics. He will be speaking to us today on pregnancy and contraception, the perspective of HIV positive and negative women. Here you go.
Thank you so much. Good afternoon all. Thank you for making our time to be here with us for this powerful session. Okay, I want to look at, it's a broad topic, looking at pregnancy and contraception. This is already a broad topic, so in this particular study, I try to see what the HIV positive and negative women actually think, the knowledge about this pregnancy and contraception. So the learning objectives will be trying to understand the pregnancy intentions and the contraceptive knowledge and use among HIV positive and negative women. Also to review on the current contraceptive techniques and highlight contraceptive technologies in development, and also as it relates to prevention of mother-to-child transmission of HIV/AIDS. If you look at this slide now, it's a slide that was adapted from the WHO Making Pregnancy Safer publication in 2007, and it clearly outlines what contraceptive methods are there in use, accessible to women of today. And if you can see, it's been grouped into 3 stages: the ones that are more effective, the ones that are in between, and the ones that are less effective. And you can also see how it's been tried to be defined in relative to effectiveness. The more effective contraception methods like in a failure rate with a result of less than 1 pregnancy per 100 women in 1 year. And examples of those are the implant, the vasectomy, the female sterilization, and the intrauterine contraceptive devices. Those contraceptive methods that will give you 6 to 12, that will fail and result in 6 to 12 pregnancies per 100 women in 1 year are the injectables, the pills, the patch, the ring, and the diaphragm. And looking at those ones that are less effective, that will result in more than 13 pregnancies per 100 women in 1 year, you see it involves the condoms, the sponge, the withdrawal method, the spermicides, and the calculations, the safe period calculations, which women usually do. And looking at this, trying to analyze this study, we looked at 237 HIV positive women and 162 HIV negative women that came for that were postpartum women in a public health facility. This was a tertiary Federal Teaching Hospital in Nigeria. Within 18 months of postpartum after delivery. So try to interview these women. I remind you that the HIV positive women in this case are women that are currently on heart. So they've been registered to be on heart therapy, and there are women that come regularly to the hospital, which we can monitor. Trying to analyze the data and the results we have to explore on the fertility intentions of these women, and also the knowledge of family planning and use according to their HIV status. This exploring these two basic components, we try to break it down to find out what they know actually about what their perspective or their intentions are when as it relates to their need for an additional child, whether they want to get more, whether they have intentions of getting pregnant again or delivering more children, adding more to the ones they have. We also try to find out what they know about family planning, because it's so easy for them to come to the clinic and you ask, do you go through any counseling and family planning? It's so easy for them to just tell you yes, just to be on the good books of the doctor. And also, it's very important to know that if they actually discuss these issues with their partners at home, or if they brought their partners to the counselor, or whether they have informed decisions, we also try to find that out. And also, their knowledge of family planning, and most importantly, the kind of contraception they use, or if they don't use any contraception, the one they would have wanted to use if they have to. From a respondent from the 236 HIV women, it's 59.3% of our respondents were HIV positive, and while 40.7% were HIV negative from the 398 women we interviewed. So looking at this slide now, find that for the women that are HIV positive, when asked of their pregnancy intentions in the future, you find that only 8% out of the 59% of them would really want to be pregnant again because of the risk they stand in the future, or the risk they will stand to pass to the child. But HIV negative women, 49% of them would say yes, they are willing to have another child. And as discussing family planning amongst the HIV positive women with their partners and with the healthcare counselors, they admitted, some 9% of them admitted that they actually went to family planning counseling and they discussed such issues. While the HIV negative women said that about 69% of them said admitted that they actually discussed such issues with their partners and the healthcare givers. And the knowledge of family planning, those ones that knew that they had to go through the process of family planning in the first place. The HIV positive women actually do a lot better because they knew in the subsequent pregnancy it's necessary to be involved in counseling. So 3% of them actually admitted to that, while 12% of the HIV negative women only admitted to family planning, which the majority of them do not even involve themselves in any family planning issues. But on their contraceptive use this time around, not contraceptive knowledge, 84% of the HIV positive women admitted to have one form or one method of contraception or the other, while 32% of the HIV negative women admitted to the use of any contraceptive method. So amongst the methods of the contraception that earlier pointed out, we find that most ones that were used for the HIV positive women were condoms, both male and female condoms. While HIV negative women were, most of them admitted to using the withdrawal method. Other methods that are adopted by both groups were using of the contraceptive pill, the oral contraceptive pill, sterilization, and the intrauterine contraceptive device and implant. So here, try to look at this data, this results, this findings, try to check the perspective of HIV positive and negative women as it relates to the pregnancy, intentions, and the contraceptive knowledge and use. We find that almost all methods can be considered for women, not on heart, currently on heart. But if these women on heart, which is the HIV positive women, we find out that there's a lot of tweaking here and there. You have to consult the doctor and find out which drugs you can use because of the drug-drug interaction, especially with the hormonal contraceptives, which is a problem for the HIV positive women. So that is why there is a need for new development of contraception. Because a study has recently shown that there are still millions of women out there that have an unmet need for contraception. And for this need to be met, it's very important to have a greater variety of methods. There should be a new, highly effective and easy to use method. You can see that most of these women, the HIV positive women, are using condoms as the most common form of contraceptive method. And you saw the failure rate of the condom is a part of the group and a less effective group. So there's a need for a highly effective and easy to use. The condom is easy to use, that is why they adopt that. Also, the better education about correct and consistent use. And asking these HIV positive women, or all the women in general, and follow that, ask them particularly what kind of contraceptive method do you think you use after counseling them on all that is available. They say most of them are off for condoms. So I asked this question: why have you considered the oral contraceptive pill, especially the HIV negative women and active pregnancy? Most of them say they don't want to use the pill because of the side effects. When you ask them what side effects they're talking about, I think there's some kind of misinformation going on there that leads all sorts of cancers. Vaginal cancer, it's going to give me esophageal cancer, it's going to give me cervical cancer, it's going to give me every form of cancer. One of them actually told me, I asked her which form of cancer, said all of them. That is what the pills will give you, all of them. I thought most times the doctors don't meet these women when they come to antenatal clinic center. So I went around asking the matrons and the hospital and nurses, okay, what is your own opinion on the use of contraceptive pills? I said the same thing. Do you use it? I will use it. Would you advise the patient to use it? No, because I think it's not safe. So you see, there's a need for a better education about correct and consistent use of this contraceptive method. Already, there are new technologies that are being in place and still currently ongoing, not been released yet. So there's the levonorgestrel releasing intrauterine contraceptive, 20 micrograms, and also the 12 to 16 micrograms. There's also the levonorgestrel vaginal ring. These are the hormonal contraceptives currently in development. And for the non-hormonal ones, there's a silicone barrier contraceptive diaphragm that's being developed. And also this new female condom that's being developed by the organization PAP. this condom, this female condom, as a difference from the current one in use, it has a softer outer ring. There are foam ducts which improve the adherence of the condom on the vaginal wall. And there's also a dissolving capsule at the tip of it, so that in case there is any problem with spillage or breakage of the condom, this dissolving capsule at the tip of it would also dissolve it. So what do we do as it stands now? The results already show that there's some success in provision of family planning and counseling and PMTC services, as it shows from the results from the HIV positive women. But new ideas are still needed. We shouldn't fold our hands, nor yet time to clap and pat ourselves on the back. New delivery mechanisms are needed. Male methods are needed. Let me ask you, female folks in here. Do you think it's okay? Do you think it's important to have some kind of drugs that men can take so that it's for contraception? It's just everything just seems to be targeted to the female folks. As you can see, the only thing that men can do actually for contraception is the vasectomy and the male condom. If men can take some of these pills, the 8-day pills, and take the burden off the women for once, I think if you can develop things like that, there should be not necessarily the pills for it, just that some male methods should be devised for. And non-surgical methods, because the word surgery scares a lot of people. They won't even want to venture into it. Drugs that can, or hormonal pills that will have limited side effects. The cost and acceptability, cost across religion, faith, social acceptability should also be developed. And if we can have something that will provide a due protection for STIs and contraception, that would also be good. Thank you very much.
Thank you very much, Chinedu. Great presentation. I just want to check before we run into questions. Is Malouk here? No. Okay. Who has? Yes, Doreen.
Maybe it's not really a question about the study, but in Nigeria, does culture really influence a lot how women perceive contraception, and does religion also play a part? Because in Uganda, it does promotion of contraception gets caught up between the culture and the religion, and sometimes it's not easily promoted. So I'm wondering, in Nigeria, does that also happen? Thank you.
Not very sure about culture as it affects the contraceptive choices and practices, but religion most definitely, especially with the Catholic faith. It's a problem, and the few Catholic women that indulge in contraception seem to be the ones that are experienced in the field of healthcare services. The doctors, the nurses, and because they know all they need to know about these things, so they can always take their informed decisions and practice what they want to do in their own setting. For those ones that are not in this field, that is why more advocacy should be. Although recently things are beginning to change with the current Pope, he's beginning to be a lot more open when it comes to contraception. So we're hoping the advocacy and the pressure would make them take the right decisions to favor the women.
Yeah. So the study was based on a facility-based study, right? For people who came to take some kind of service, and then you ask them the questions about contraceptive use. So what's the rate of healthcare service utilization in Nigeria?
To access medical services, especially when you're pregnant. I just during the Christmas period, there was this lady that came into the hospital in labor, and I asked her if she had been, where did she go for her antenatal services? She said no, she never went for any. So this is a setting that is not really rural, if you can say. So it's not really about where you're from, whether in the urban or the rural or in the midway in between the two.
Most deliveries are home deliveries?
No, not really. Things have improved. It's no longer that way, except in some parts of the country, it's still like that.
So the following question is, come to hospitals, take the services or avail the services. That means you're really concentrating on people who access hospitals. There are a whole lot of people who you have no clue what's going on, and maybe.
Yeah, this is just trying to find out the pregnancy intentions and the contraceptive knowledge. If these poor results were gotten from HIV negative women that actually come to the hospital, then it doesn't paint a good picture for those ones out there that don't come. So that is why.
So things are much worse when you think about everything.
Yeah, a lot of work needs to be done.
Yes, in the back?
There's a way to ascertain that the women who made the choices for condom were able to use it. The reason is that within the socialization in Nigeria, women don't really have power to make the choices, those kind of choices in their relationship. And if there is a discordant couple for any reason, and the purpose of the woman is not open to her partner, is there a way to measure or to find out if clearly she was able to do that? The other one is, in doing this, the hospital where this was done, is there a support group for women who test positive or men who test positive? And is there any role that support group plays in actually bringing women to make choices for contraceptives?
There's what I call it an initiative found in most government hospitals, federal institutions, called the Heart to Heart Center. These ones are just there specifically to administer counseling, treatment, and drugs to HIV positive people, not necessarily pregnant women at this stage. And so it's a focused group all on the HIV. So there is this support group there. First of all, you get the necessary counseling, and you're registered with your CD4 count, you know when to start the medication or not. So that is there already. But the other question about if the use of a condom can actually be measured, that is a tough one. We only take the word of mouth, what they tell us. And I agree with you what the social problems are in Nigeria and concerns that the use of the female condom is very low or non-existent. So it's always a situation where the man has to agree, I'm going to use the condom. So that is why most times, like I said from the study, you find out that the most common contraceptive method used by the HIV negative women was withdrawal. While in HIV positive, because of the counseling they might have gotten from the Heart to Heart centers, and they know the risks involved of vertical transmission and all that, so the men seem to use the condom.
Yeah. So thank you very much.
Thank you.
So the presentation is Perceived Quality and Benefits of Postnatal Care Among Women of Reproductive Age in Mukano. Doreen?
Thank you. Good afternoon, everybody. Thank you for coming. I'm going to share with you work that I conducted in Mukano district, as like Ted said, as part of operational research during my field assessment. And it was intended to assess the perceived benefits and quality of postnatal care among women of reproductive age in Mukano district. A brief introduction. Globally, we still know that maternal mortality is a major public health problem, and in Uganda, the maternal mortality ratio stands at 438 deaths per 100,000 live births. And our literature in Uganda shows that 60% of these maternal deaths occur within the postnatal period. That's the time after delivery, especially in the first week after birth. And yet, the health sector strategy plan reports that only 26% of mothers utilize postnatal care within the first week, and this could contribute to this during maternal deaths that happened within this postnatal period. Also, in the district when I was there, during my field attachment, there were concerns from the maternal and child health department that mothers were not utilizing postnatal care, despite the efforts within the district to promote the use of this maternal health intervention, including putting up a postnatal care clinic, the use of the mother's passport to ensure that mothers know the routine checkups that they have to go through even after delivery. And also, in Uganda, community health workers have been involved in the promotion of postnatal care use, where village health team members identify newly delivered mothers and they refer them to the facility for checkup to receive postnatal care. However, with all that, the district records show that postnatal care was still underutilized. And yet, we realized that if this maternal health intervention was utilized, it could promote safe motherhood by improving the continuum of care for a mother. And in a way, this would improve maternal health outcomes when women receive timely postnatal care. So based on that background, we sought to identify the perceived benefits of postnatal care among women of reproductive age, because we did study on a hypothesis that if a mother or a woman of reproductive age could perceive a benefit of this maternal health intervention appropriately, most likely they would use the intervention. And also needed to describe what is perceived as quality postnatal care among the study population. This study was carried out in Mukono, in Uganda. On my left, that's the map of Africa. Uganda is located in East Africa. And Mukono is located in central Uganda, next to the shores of Lake Victoria here. And it's approximately 20 kilometers away from the capital, Kampala. So it's really a very urban district. So in our method, our study population were women of reproductive age, and we used a cross-sectional study design. We used a semi-structured questionnaire for data collection. And our sample size involved 100 respondents with those stated assumptions. And in order to sample these respondents for this study, we used a multi-stage sampling technique where 2 parishes were randomly selected from 43 parishes for this baseline study, and then 5 villages were selected from these 2 parishes, each, and then we were able to sample the respondents. This slide shows some of the results. I wasn't able to put up most of the results because of the time limitation. But the mean age of the respondents was 26 years of age, with a standard deviation of 5.9 years of age. And majority of the respondents reported that they had ever been married, and 46% of them were housewives. And when respondents were asked if they had ever given birth, most of them, 95%, had ever given birth. And of these, the mothers, 86% reported that they had had their most recent delivery from a health facility. However, when the mothers, those who reported that they had ever given birth, were asked if they used postnatal care, received postnatal care on their most recent birth, only 33%, that's a third, reported that they had gone back to a facility to seek postnatal care. And about the first objective, when respondents were asked what they thought were benefits of postnatal care to a mother, specifically to a